Mayo Clinic presents the Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda.
Everyone, welcome to the show. This is Always On EM, a podcast about emergency medicine from Mayo Clinic. My name is Venk Bellamkonda.
And I'm Alex Finch.
We're your two co-hosts as usual. We are very excited about this episode. In fact, before we recorded our first episode, this was one of the ideas that Alex has been burning to do, but we wanted to wait till we had enough of an audience. That's you all. Thank you for tuning in to make this worthwhile. And so, Alex, why don't you tell our listeners about what are we going to do today?
We are going to talk about ECPR and ECMO. I've been looking forward to this for years, and I'm very excited to introduce an expert on this topic and somebody who I consider a close personal friend, Dr. Suraj Yalamuri. Welcome to the show.
Thanks, Alex. Thanks, Venk.
We're so grateful you're joining us. Thank you.
Oh, this is awesome.
This is Venk jumping in after the interview to properly introduce you all to Suraj. Suraj received his medical degree from the University of Iowa Carver College of Medicine and then went on to complete anesthesiology residency at Duke University School of Medicine. He also later finished critical care medicine fellowship at Duke as well. If that wasn't enough, he went to Paris, where he received a diploma in ECMO before joining Mayo Clinic as a consultant in both the divisions of critical care anesthesiology and cardiovascular medicine. He has numerous leadership roles in a variety of spaces, touching on research, ECMO, LVAD, and more. Also, he is already the recipient of the Distinguished Clinician Award from the Mayo Clinic Department of Anesthesiology. From a research perspective, he has received multiple research grants and parlayed them into over 30 peer-reviewed publications. As an educator, Suraj runs a remarkable high-fidelity simulation in our department to assess and bolster our system of ECPR ECMO care each year, and provides lectures and discussions anytime he is called upon. He is an invited speaker outside of Mayo at all levels, including around the globe, to talk about ECMO and ECPR as well. If I'd brought this up live with them, I think it would have made them both uncomfortable, but I'm going to take advantage to share now. Alex and Suraj are part of a fantastic educational crew who travel to New Zealand each year to teach about ECMO. The event is outstanding and usually newsworthy. These guys are truly best in class. Okay, let's get back to the recording now, but shh, don't tell them I told you about the New Zealand stuff.
Is it okay if I share a little bit about how we met?
Yeah, go ahead.
I first became interested in the concept of ECPR after a difficult case in the emergency department, and I set up a survey for the entire Mayo system and included people in Arizona and Florida. And this was actually under the mentorship of Venk. He had this idea, and I set up all of these case scenarios and sent it to anyone who interacts with ECMO. So CV surgery, all the ICU consultants. I was surprised, first of all, at the sheer number of people who were willing to interact with a random residence survey. So that, first of all, just incredible kindness amongst consultants on this topic. But in every question, there was one person who wrote an entire paragraph of response. Subtle nuances in the case that would cause them to do one thing or another thing. It was the most insightful and thoughtful response, again, to someone who was just curious about the topic. I had never met this person, and the last one said, this is Dr. Yalamuri. If you have more questions, I'd love to talk. And I reached out because I said, this is a person I have to meet. And it was the beginning of a long-term collaboration on ECPR in our department.
I think I just found a sucker. That's really what happened. I was like, I want to get this off the ground at Mayo, and who can I talk to in the emergency department? And it happened to be a resident. I mean, what better way?
Not just any resident, one of the best that we've ever had.
Indeed.
So
yeah, it was awesome.
It's a partnership that's produced a lot of great fruit.
It's been an amazing journey. Overall today, you may be listening to this show and have a deep passion for ECMO in the emergency department, or you may not know a lot about it, and we want to try and touch on all of those things. And so why don't we start a little bit at the basics?
Yeah.
First of all, what is ECMO and how did you get interested in it?
Yeah, I mean, my background is in cardiac anesthesia and in ICU, and a lot of what I do is take care of those patients in those settings. Either we're putting them on ECMO in the cardiac operating room, or we're taking care of them in the cardiac ICU as a bridge to transplant or recovery because the pump run didn't go well, or, it's ARDS and they're on VV ECMO. These are the type of patients that more often than not I'm taking care of. And that's what I trained to do in fellowship. And a lot of what I also did in fellowship was go on retrievals, right? Because I was trained at Duke, and in the Southeast, we were a pretty big ECMO center. And we had a big encashment area. And so we would go elsewhere and bring patients back for advanced therapies. So that's how I kind of got interested in all of it. And when I came to Mayo, it was, well, how do we continue to do more of the same here?
When you say retrievals, you mean to go get donor hearts? Is that what you mean? Or patients retrieving them from another hospital to bring
patients retrieving from another hospital. Yeah. There would be patients in rural areas or other hospitals where ECMO therapy was not feasible for them. And then we would fly out and put them on and bring them back, or somebody else would have already put them on, and then we bring them back for more advanced therapies at Duke.
That's awesome.
Right. So it was kind of fun in that regard. And then as a resident and as a fellow, especially as a fellow, to be able to do those things kind of instills your passion even more in it. And in some respects, you start becoming a believer that this thing will work.
And that's a key term that I've heard a lot about at conferences, and we're going to talk about that later in the show. What is it to be an ECMO believer, and what is the literature on this topic? But let's start even more basic. When we say ECMO, what does that mean? And how is it different from something like cardiopulmonary bypass?
Right. So ECMO stands for extracorporeal membrane oxygenation. Fancy way of saying take blood out of the body, send it through an artificial membrane that oxygenates it, removes the carbon dioxide, and sends it back in. Depending on where you send the blood back in, you support one organ versus the other. So if you take the blood out of a vein, oxygenate it, decarboxylate it, send it back into a vein, such as the internal jugular vein or a cannula that sits in the SVC, you're now doing VV ECMO, right? The heart is taking care of pumping everything, but we've effectively sort of taken over the function of the lung. Whereas if I do the same thing, but I send the blood into an artery, let's call it the femoral artery, now I'm doing the work of the heart and the lungs, right? Because whatever amount of blood that I'm taking out of that vein and sending it back into the artery is now bypassing the heart. So I'm supporting the heart and I'm supporting circulation. So that would be where somebody is in heart failure, or for our topic, ECPR. It really is just a way of supporting a failing heart or a failing lung. And when you support a heart, you automatically support the lungs just as a consequence of what we're doing. Otherwise, you would create a shunt. And it's what we do for cardiopulmonary bypass every single day. The surgeons would do a sternotomy and put a cannula in the right atrium. Blood comes out of it, oxygenate, carbon dioxide removal, and goes back into an ascending aorta, right? The only real difference between ECMO and cardiopulmonary bypass is that we don't have a reservoir in ECMO. So in cardiopulmonary bypass, the blood that comes out of the vein goes into a holding tank, a reservoir of sorts, and it sits there. That's how we can empty out the heart and empty out the lungs for the surgeon. Whereas in ECMO, we don't do that. We don't have a reservoir. We just sort of bypass the flow a little bit. So that's the major difference.
So if I'm hearing you right, VV ECMO replaces the lung function for the patient. AV ECMO or VA ECMO is both organs.
Yeah, exactly.
Okay. And then the difference with the bypass, as you mentioned, is the reservoir.
Yep.
And that's because the heart is empty during the surgery, and that blood needs a place to be stored.
Exactly. We just need to have a way to decompress the heart. And also, when they're doing cardiotomy, if you don't have a reservoir, that blood would escape from there, right?
That makes sense.
And then you would need to siphon that and hold it in a holding tank. Also, because the reservoir also prevents the air from coming through into your oxygenator or into your pump head, and the air just collects in the reservoir. Whereas on ECMO, you don't have that capability. That's why everything has to be very, very tight. And this is why we worry about in ECMO any air escaping into our circuit, and we worry about are all the bags closed or all the clamps on, because we don't want the circuit to get airlocked.
Interesting. I didn't know that.
I didn't know that. Already, I feel like I've walked out with my money's worth understanding just that. Thank you so much.
Yeah. So let's create a little bit of a mental model for our listeners. When you're trying to decide a patient who's going to get VV ECMO, what types of consult are you getting, and who is that patient? And how is that different from a patient that you get a call to come do VA ECMO?
Sure. I want to start off just taking a couple steps back, though, and just saying every single time we do ECMO, we are not solving the underlying problem. So I want to emphasize that to people.
So we can't just walk around on ECMO every day for the rest of our lives.
I wish, right?
It seems like that fixes everything.
I mean, we've done it. We've done it where we kept people on ECMO for like a year plus, and we've taken this patient out on to see New Year's fireworks in an ambulance and that kind of stuff, right? So we've done that. But at the end of the day, we're always working towards something, right? All we're doing when we put a patient on ECMO, it doesn't matter if it's VV or VA, we're buying time. We're buying time in order to fix the underlying problem. If it's a heart that's not working, we're asking ourselves, what can we do to get that heart to work again? If the lungs are not working, we're asking ourselves, do the antibiotics need more time or something? Do we need to do something else to get the lungs to work again, right? So we call those things bridges to recovery.
Okay.
Or they're bridges to transplant, because we've already determined that we've approached end-stage heart failure or end-stage lung failure, and we are now supporting the patient until we can transplant the patient. So then we have bridges to transplant, right? So notice that it's always a bridge, right? Bridge to recovery, bridge to transplant. Now, the last one can be a little controversial, but what I'm going to call it as bridge to decision or bridge to discovery. We don't know all of the answers just yet on what's going to happen. And it could be an urgent enough scenario or it could be an emergent enough scenario that if we don't do something right now, that this patient would be lost. We may put them on ECMO as a bridge to discovery, like we find out more information to determine which pathway they're going to end up in. So there's always a bridge. ECMO by itself doesn't solve the problem. Going back to your question on what am I thinking about when I get a VV ECMO consult, automatically what I'm thinking is, okay, their lungs are bad. How am I going to get their lungs better? And what am I going to use this for? Is this ARDS after influenza? And do I just need to have this patient on ECMO for a couple of weeks? You know, have we gotten to the point where they have been on a mechanical ventilator for so long that there's nothing left to recover? So right now, SpO2 is bad, PaO2 is bad, you know, your PCO2 is bad, they're acidotic and they're hypoxemic, you know, all of these things. Yeah, that's why we're going on. But what I look at it is, what do I have left? And if I don't have a pathway to recovery, and the next thing I start asking is this a pathway for transplant? I approach all of the patients in that same manner. What are we doing the ECMO for? And what are we buying time for?
I think that that's such a interesting and thoughtful approach. Even the way that I asked the question was different, and it comes from our differing initial approaches. I'm usually the person asking for the consult, and it's often based on the thing that is before me. I have a patient in ARDS, and I need to know, will you do ECMO now?
Right.
From your perspective, prognostication of a pathway is just as important as the pathology, because the prognostication determines the bridge. That's a very profound thing. Even for me, I need to think about that more when I'm asking the question of you.
Yeah, I mean, I think the best way to think about ECMO is like any other medical therapy. You know, I think we get blindsided by the fact that this is some magical box, or it's resource intensive, or any number of things that are thrown out there. But at the end of the day, it's like any other medical therapy for me. What I'm asking is the benefits of this medical therapy outweighing the risks of this medical therapy? And if the answer is yes, then we do it. If the answer is no, then we don't. This is my personal pet peeve, but I'm going to share it because I feel like you guys are not going to judge me too much.
No judgment from us.
Yeah.
Nor anyone listening.
The internet is a judgment-free zone.
Absolutely.
Great. Now that we've established that. But my pet peeve is the word a candidate for ECMO.
Mm-hmm.
I hate that term. A patient is not a candidate for anything. I mean, because I think when we say that a patient is a candidate for something or not a candidate for something, for me, that implies a value judgment on the patient. Mm-hmm. And that's not what we're really doing. We don't talk about if the patient is a candidate for intubation or if the patient is a candidate for a chest tube. We say, will the chest tube benefit the patient? And ultimately, that's what we're asking of ECMO. Is this a therapy that will ultimately benefit the patient? And I can completely see where you're coming from, where you have a patient in front of you in most of those cases where if you're in the emergency room, they're dying in front of you. Maybe they have a PE or they have they've had a cardiac arrest and they are dead at that point where you're trying to resuscitate them, right? And you're saying, well, help me. As a physician, help me and help this patient. What I'm saying is, I know, but just because I put them on right now, they may not die in your ED bay, but they may die up in the ICU. So I'm not net benefiting the patient. The lens that I'm looking at that scenario is the therapy that I'm going to provide outweighing the risks of what I'm going to do right now? And there's a lot of different calculations that go into it, but ultimately that's how I'm thinking about it.
That's super helpful. Super helpful. And going back to the different bridges that you mentioned, it felt like most of the bridges involve dysfunction of the heart or lungs. But occasionally I've seen people, for example, with sepsis being considered for being placed on ECMO.
Yeah.
Help me understand how that fits into the bridge model.
Yeah, it doesn't quite seem to work, right? You're thinking distributive shock, how does that work? And you're right, if it's purely a distributive shock picture in sepsis, we're not going to help them on ECMO. The data is, I don't want to say like the data is great and clear on it because there's no data in ECMO that is great and clear on anything. It's not like we have any large scale trials. But whatever we do have would indicate that in order for a patient on sepsis to benefit, they need to have cardiac dysfunction. If their cardiac index is less than 2.4, less than 2.2, and we put them on ECMO, then we see that maybe there's a benefit for them to be on ECMO because their hypotension and their lack of perfusion is now not just purely from a distributive shock. There's an underlying cardiogenic shock component.
And that's the piece that we're bridging.
Exactly.
That's super helpful.
I have a much clearer picture. The general function of the device, we have VV and VA, and there has to be a purpose, a bridge to somewhere, and sometimes a bridge to decision. But overall, we have to envision a prognostic future where there will be a benefit to the patient. We said in VV ECMO, this is a lung predominant process, and a common mental model might be ARDS of some kind. How about VA ECMO? What types of patients do you find you get consulted on for VA?
Yeah. Anytime that there's cardiac dysfunction is when we would get VA ECMO patients on in general, is what I would say, right? So you could imagine a patient in the CCU, for example, who had an acute myocardial infarction. Maybe they got their coronaries opened, and then they're in, and they're on inotropes, and they're in shock, and things are not progressing very well, right? So that's the kind of patient that we would get consulted on. And that's where I would say, okay, well, I expect this heart to likely recover in about 72 hours, maybe 96 hours. This is what I would call a short run. And you put this patient on veno-arterial ECMO or VA ECMO. Or it could be a patient who comes in end-stage heart failure, and they've been managed on goal-directed medical therapy. And they come in heart failure exacerbation, and maybe they're being considered for an LVAD or they're known LVAD candidate or a transplant candidate. And then we go, okay, great. We've hit that point where we're likely not going to get this patient out of the spiral right now with this heart failure exacerbation. So we're going to go on ECMO as a bridge to transplant because we know that we're already approaching that. We also see cases where a patient has intractable VTs. You may need to put them on ECMO until their VT can be better controlled, either with ablation or for other medical therapies to work. We even do it in order to support high-risk ablations in the EP lab. Right? Because a patient can't be in sustained VT and be perfusing and do well enough because their myocardial function is so poor. Well, if we can put them on ECMO during that procedure, then they can stay in that rhythm and they can map it and then actually ablate it.
So we've talked about a lot of phases of cardiogenic shock, but there's the ultimate cardiogenic shock, which is
cardiac arrest.
And that's where I work with you the most commonly. For our listeners who may not have interacted with a circuit, can we start with, say, 1 cc of blood that's currently in the patient's right atrium? When we talk about VA ECMO for ECPR, can you help us trace where that blood goes and what it's going through?
Yeah, I love this. I kind of tell the fellows to do this all the time. It's like, in organic chemistry, you're taught to be the carbon atom.
Yeah.
This is in ECMO. I think it's best if you imagine you're the red blood cell and you go, where do I go?
When you're
what are my
passionate,
options?
when you're passionate about ECMO, like this is what I do every night before bed. I'm just like going through the circuit,
Not counting sheep,
not counting sheep. It's RPM.
tracing the red cell.
So it's an ECPR case,
Yep.
and we're cannulated in a very traditional way.
Bread and butter.
Bread and butter type of cannulation. All right. So you have what we call a multi-stage cannula, which effectively means a venous cannula with multiple holes in it that is sitting somewhere in the right atrium.
Okay.
Okay, draining the blood.
Where is the perfect place for it to be? This is for because
Yeah.
I hear a lot of teaching. Where does Suraj Yalamuri want the tip of his venous drainage catheter?
In the SVC.
In the SVC. Okay.
In the SVC.
Okay.
But it's entering through the femoral vein.
That's correct. Yeah. So from the femoral vein into the SVC, I want those holes lined up from the SVC to the right atrium to the IVC. So we're draining everything in via ECMO.
Okay. I know where the cannula is.
Yeah.
All right. So where's the other cannula?
The other cannula would be we access the femoral artery, but the cannula is going to be long enough that it likely sits in a normal adult patient in the external iliac artery.
Okay.
It's not even going to try to make it into the abdominal aorta.
Okay.
Right? So that's where
So that's a much shorter cannula.
much shorter cannula.
All right.
Before we trace the red cell,
Yeah.
this is a very elementary question.
Yeah.
So you're going to push blood directed proximally to the heart through the femoral artery iliac.
That's right. So let's say you're cannulated the left femoral artery.
Okay.
So the tip of the cannula, where the blood is going to come out, is sitting in the left external iliac artery.
Yeah.
The blood's going to come out of there, and it's going to go 3 different ways. It's going to come out, and part of the blood, if there's space around the cannula, is just going to sneak around and go antegrade down the iliac artery to the femoral artery, the profunda, and the SFA, and perfuse the leg.
Okay.
Most of the time that doesn't happen, or it happens in a very poor fashion because the cannula itself will be occluding a lot of it. So that's why we've put in what we call a distal perfusion catheter in the SFA.
Oh.
The remaining portion of the blood comes out of the cannula and goes retrograde up the external iliac artery. And then you get to the bifurcation of the aorta, right? There, some of the blood will go antegrade down the right external iliac artery and perfuse that leg. And the majority of the blood will then go up, retrograde up the abdominal aorta.
Okay. And so that's how the heart might get directly oxygenated blood from the
Exactly.
circuit.
Yep.
Okay. Thank you.
Yeah.
Sorry.
Yeah,
All
so
right.
the coronary arteries are really at the very distal end. And
That's
they're
what
the
I was
last
worried
ones,
about. That
right?
like, I don't want the heart to get oxygen, that secondhand oxygen.
I was
after my
always told
toast.
leg first. That leg
Yes,
always
leg
gets
first.
oxygen first.
Exactly. All right. Okay. Let's trace that 1 cc of blood.
Yeah, so let's say you have a red blood cell that is sitting in the right atrium through with this type of cannulation that we chatted about, right? So in the right atrium, the blood really then has 2 spots that it can go down. It can either go into the venous cannula, or it can continue along through the native circulation. The native circulation is what it is, so we don't really have to discuss that, right? It just goes through the lungs and the LV and gets ejected. Whereas in the ECMO circuit, the blood goes through the venous cannula, so down the venous cannula, femoral vein, out, so it exits, becomes extracorporeal, out
So
of the
it's
femoral vein.
pulled into the cannula through
Yep.
those multiple holes.
Yep.
And then suddenly it's in the cannula being pulled down the IVC, all in this huge garden hose of a cannula.
Yeah,
until it
usually like a
comes out.
25 French cannula, right?
These are
Yeah.
enormous. And then it's being pulled out. And
Yes.
now we're extracorporeal.
Yep.
Where's it going then?
So then, once it comes out, depending on your ECMO circuit, you have a length of tubing that then attaches to the cannula. As far as a red blood cell is concerned, there's no change. It's just still another pipe. It's just going to go down that pipe. And then what is generating that force, that we call it negative pressure, but in reality, it's less than atmospheric pressure, right? That's what we're saying when we say negative, because there's no such thing as really negative pressure. So it comes through, and you have a centrifugal pump that's spinning. So it enters the pump. And so then it goes through the pump, exits the pump. So now it's on the positive pressure side of the circuit. And there's another length of tubing that connects the pump to the oxygenator. So then the pump on the positive pressure pushes that red blood cell through the oxygenator. And in the oxygenator, there is a membrane, much like our lungs. So you have gas on one side and you have the red blood cell on the other, and they never touch. Okay, so you have a membrane that is separating them. But gas exchange happens across that membrane. So oxygen diffuses in, CO2 diffuses out. And at the same token, in the oxygenator, there's a countercurrent of water running. So, and again, the water doesn't touch. It's just a countercurrent. And because the water is set to a set temperature, as the blood goes through there, it warms it up or cools it down, depending on what the temperature is of the patient to compare to what we've had it set to. So now the blood coming out of that oxygenator is oxygenated, decarboxylated, and appropriately temperature controlled. So it exits the oxygenator, still on the positive pressure side. Now instead of being dark red, it's bright red, and then goes through tubing into the arterial cannula, exits out of that arterial cannula, and goes back through that same blood flow pattern that we talked about.
With the three options.
Yeah, exactly. And this is the part you were talking about. So it's entering and it's being ejected up essentially the entire length of the aorta. And this is exactly what Venk was saying. So if the heart is beating, there's minimally oxygenated blood potentially coming through the heart, or depending on your ventilation settings. And then there's well oxygenated blood coming up the aorta. Potentially they're hitting each other. How does that work?
So you're talking about sort of this competitive flow is kind of what you're describing. So remember that red blood cell that we talked about, it can either choose to go into the venous cannula, or I say choose like it has a mind, but you know what I'm getting at. It can either go into the venous cannula, or it can continue through the native circuit. The proportion of how much those blood flows happen is dependent on the size of your cannula, as well as the amount of blood in the heart, as well as how much flow you're deciding to set through the circuit, right? So let's for a second imagine that it's 50-50. There's 50% ejection for your native circuit and 50% through the ECMO circuit. So now the heart is full and it's ejecting. So as the blood that comes out of the heart is now competitively sort of like mixing with the blood that's coming out of your ECMO circuit, where that mixing happens, or that mixing cloud happens, is completely dependent on the pressure of the ECMO circuit and the pressure of the blood coming from your native circuit. If you were to imagine where that is, there's three different spots that we can really two that we can suck it out and identify from, right? So if you sample the right radial artery, you're saying, is the mixing cloud in and around the innominate artery? Or you're sampling it from the left radial artery, and you're saying, is this in the subclavian space? Is that around there in the arch? Now, to get back to kind of what you were getting at, is what happens if the oxygenation of the blood is pretty poor, because during cardiac arrest and compressions, maybe there's pulmonary edema or chest contusions and you're not oxygenating properly. Well, if the heart is ejecting that blood, you can imagine that's poorly oxygenated blood that is mixing with very well oxygenated blood. And this is something that we call north-south syndrome or Harlequin syndrome. And it's kind of what we want to avoid. And that's why in ECPR, we always say, put in a right arterial line, right upper extremity arterial line, because that's our first measurement point. Because those coronaries, right, are seeing, as we talked about, they're the most distal portion of the ECMO circuit, but they're the most proximal of your native ejection. So if you have bad or poorly oxygenated blood coming out of the left ventricle, the coronaries are going to see that first.
That makes a lot of sense.
I know there was a lot of anatomy.
It's expertly described. I'm picturing it right now. It's very, very helpful. Suraj, this is brilliant. And I'm understanding this in a way that I haven't before. It's bringing up new questions.
Yeah.
So I'm assuming then when this red cell has left the venous system and it's entering tubing, there's a huge amount of space there that needs primed with, I'm assuming, blood.
Yeah, so if it was a neonate or a very small pediatric patient, we would prime with blood, and we would actually in the background keep circulating that blood through the circuit so it actually even stays oxygenated before as it goes in. But in adult patients, we just prime with saline through there. And it's a sizable volume, but it's not too much. So a standard oxygenator takes about 500 mLs to prime, and the rest of the tubing is maybe another 200 or 300 mLs. So you're talking about, around, 700 to 800 mLs of fluid in there. Okay. Now, the important thing to remember is it's not like you gave 800 milliliters to the patient, because you've also extended the patient's vascular system. Because even though it's extracorporeal, that is still connected to the patient's system now. So if the patient had a blood volume of 5 liters in their compliant vasculature, let's say, and we didn't change the compliance, and when you add the ECMO circuit, and that's 800 mLs, now the total volume is 5.8. So if you were actually going to bleed the patient out, so let's say all of that was air, and you were going to bleed out the patient to fill it and retrograde prime with the patient's blood and go on, well, now you've actually put the patient into a bit of a hemorrhagic shock, because you bled the patient 800 mLs. That 800 mLs is sitting outside of the body, right? So yeah, you kind of give them a volume bolus, but the net circulating volume is still the same as it was before.
Okay.
If that kind of makes sense.
It does. And that volume isn't too unreasonable. And you can trip in the ED and get a liter of fluid in you.
You still dilute the blood out as well. So it's something that we need to keep an eye on.
That was going to be my next kind of two questions would be, we've talked about the mechanical operations.
Yeah.
What about biochemically? Do we need heparin, I'm assuming, for these patients so they don't clot in the circuit?
Right. Yeah. So plastic and blood doesn't like each other. We have heparinoid coatings on the circuit, things like that. Some are coated, some are not, all of these different types of things. Everything is prevented at making the blood flow through it slicker and without any clots happening. That being said, we would still, for veno-arterial ECMO, highly recommend that we anticoagulate the patients, and we routinely do. Heparin is the choice, but when we are going on, easy to find, easy to bolus, easy to control. Look for an ACT target of more than 200 and go on in this type of emergency scenario. We don't have to think too much more about it. Around anywhere between 50 units a kilo to 100 units a kilo of heparin does the trick. I try to not to think about it too much. My goal whenever I approach these things is to have as little process going through my mind as possible so I can focus on the procedure itself or other things. As far as I'm concerned, 7,000 units of heparin versus 10,000 units of heparin are the same thing. So I always just say give 10,000, but if you want to calculate it out a little bit more, I would say those are your rough rules of thumb.
If you want to make it harder for yourself.
Yeah.
I appreciate that.
You mentioned an ACT target.
Yeah,
is that what you
activated
said?
clotting time is what that stands for. And it's purely a test that looks at how long your blood takes to clot. And it's in seconds. So when we say an ACT of 200, we mean it takes 200 seconds for the blood to clot.
And it might benefit us to talk through the cannulation and when actually do the heparinization and things like that, because our physiology is going to change. So let's talk through a 65-year-old gentleman who has coded in my ED, and I've been doing CPR for a while, trying things. Nothing's working. Yeah. And I give you a call. When would you want an ED physician to give you a call, and what are you thinking as you're coming down?
I would say what you've just described is an in-hospital witnessed cardiac arrest. As somebody who sits the chair and responds to these from an ECMO standpoint, I want to know sooner rather than later.
What is sooner?
So let me put it this way. We ran these sims, right? So from the moment you call to the moment that I can physically be down there, the team can be down there, was roughly around 3 to 5 minutes based on where I was in the hospital when I got that call and how long it takes me to get down to the emergency department. Does the elevator stop on every floor, or does it come all the way down at once, kind of thing, right? So now you're already burnt, worst case scenario, you burnt 5 minutes. It takes me to come down there, chat with you, get a little bit about patient history, 30 seconds to a minute to get all of that, maybe make a call. Then we start the process of cannulation. And we say we try to get on in less than 20 minutes, and we give ourselves approximately 30 minutes. Again, let's take best case scenario. 3 minutes to get down there, 30 seconds to do and make the call, 20 minutes to go on. Even if you call me the moment the patient had cardiac arrest, that is still 23 and a half minutes in order to get the patient on flow.
Okay.
Maybe Dimitri Anopoulos can get on in 4.5, but it's, but this is our target.
I've seen you work some magic very quickly.
But my point that I was trying to drive at here is that if you wait 20 minutes to call us, and then it takes us 23 minutes to get on, now you're pushing into that plus 40-minute time frame. And remember that 40 minutes was kind of that magic number when you look at that shockable rhythm, ECPR, neuro intact survival rates. After 30, it starts to fall off. And once you go past 40, it really starts to fall. Okay. Right? So use that in your calculus when you may want to call us. I'm not saying call for every single one right away, but waiting too long is of really no benefit here. I would rather be called, come down, and you tell me we got ROSC. Okay, great. Then we can chat about whether the patient needs something for cardiogenic shock. Yeah. Or you call me and you come down and I'm in the middle of getting my sheets in, and then we have a pause point there, and you say, okay, we got ROSC. Okay, great. At the worst case, you have an arterial line and a central line that you can use for your resuscitation. That's
certainly pretty useful. So you walk into the room. Let's just call this the perfect code. Yeah. And let's walk through the steps.
So it's a code you're running.
Absolutely. Every code that I run is the perfect code.
Right.
But let's talk through kind of the steps and the rationale behind those steps. Yeah. So you've at this point made the decision that you want to go forward. Right. Let's talk about it from your point of view. So what is your team starting to do, and what are your first steps while my team is doing CPR? Yeah. So our main first step is to get the people that we need at the bedside. So it's not just you. It's not one doc that does ECMO. No, right? Who else is coming? So I may come down to be the first person on the phone with you to initiate, but I can't do this by myself. So we need a second cannulator at a minimum. We need our ECMO specialist, who is effectively trained in giving us the equipment that we need, who in the middle of the night when perfusion is not in-house can actually run the pump for us. So we need them. And then we also need the rest of our equipment, right? Okay. So we have a backpack that I can bring with me that has all the stuff, but it doesn't have the cannulas in there, and it doesn't have the pump. So somebody has to bring us the pump. And more importantly, we still rely on a multidisciplinary team. So we have our cardiac surgical fellow comes down, or in-house, if the cardiac surgeon is here, the cardiac surgeon comes down. Plus, we need a way to guide our cannulas. We need to see where it is. I mean, we just mentioned we're going to get up into the SVC from the femoral vein. Well, we're not going to push it up there blind. We're going to use echo to do it. Okay. Certain places may use fluoro, but we rely on echo. So we need somebody to run our echo probe, and we rely on our cardiology procedural team coming down in order to help us. So it's really about the very first stage is what I call the communication stage. We need to get everybody there in order to be successful. Okay. So I break it down into communication, pre-cannulation, cannulation, and post-cannulation. That's kind of how our checklist is set up. Okay. So once I decide to go on, we set up a calling tree. So all I do is I call the emergency operator here, and I tell them I'm activating for emergent ECMO in the ED, and that automatically sends the page to all of these people. Okay. It also puts the operating room on hold, and it gives a heads up to the cath lab. So because we anticipate that those are areas that we may potentially need. So that's step one. Step two is all about preparation. So we got to get set up for success, because remember, it's going to take us 15 to 20 minutes to do this. In that 15 to 20 minutes, what we are looking for is good CPR to keep the brain alive, right? Because if we just say, okay, the ECMO team is here, we're done, it doesn't matter how quickly I get on. That brain is not seeing perfusion. We're hosed. Okay. So it's about how do we keep the ACLS team that's already there continuing to be highly functional, while a new team, let's call it the ECMO team, the ECLS team, is coming in and sort of merging with the ACLS team. And how do we do that in an efficient manner that's the least disruptive?
So that's really the second stage of the process.
So there's a team that's continuing ACLS.
Yep.
Let's get a couple of yes
It's
or
your
no's
team.
or maybes.
Yeah.
All right. So patient is intubated or is just with an SGA?
Yeah, so we use TEE in
Okay.
order to guide ourselves, and you would love to have a way to do TEE with an LMA, but we can't,
Okay.
right? So that's where we say, the ACLS team, can you please move forward with an intubation if you
Perfect.
haven't already?
So my patient has a definitive airway at this
Yeah.
point, and we have our Lucas device on. Are we doing anything weird with the rate, or we can just continue on with our normal rate?
I would just say continue on with your normal rate.
Okay, then we have some ACLS meds, things like amio, okay to give?
I don't see it as a bad thing to give.
Okay.
I also don't see it as a good thing to give.
Okay.
And then the reason is, I would make the argument that if you're at this stage now, that don't give any meds.
Interesting.
Because what you're telling me is I am in refractory or recurrent malignant arrhythmia that I cannot get out of, and it's refractory to medical therapy, right? So at that point, we've established the fact that your medical therapy has a low chance of success. So the only thing that I want to borrow from that is what keeps the brain alive. So do continuous chest compressions. That's going to keep the brain perfused until I can get on.
What about epi? Epi has some good evidence for ROSC. What do you think about that?
I think it does, but wouldn't the Paramedic 2 trial say that it has no good evidence for neurologically intact outcomes?
Neuro outcomes are later. ROSC is now. ROSC is in front of me. Okay, so
But it makes it harder for me to cannulate. So when
Okay.
you give epinephrine and you give vasoconstrictors, those blood vessels are going to squeeze down. They're going to become smaller than they already are, and they're going to tend to spasm more. So that leads to a higher chance of us not being able to get into those arteries, and also a harder or a higher risk of potentially hurting them. And so since there's effectively less chance that those medications are going to help, my argument is, let's not give those. Let's give the best opportunity for the ECLS team to get those cannulas in and not give the medications that have a very low chance of changing the outcome. Venk, I know you've been dying to ask this question.
Yes, exactly. You said in your mind, you would prefer us to avoid giving medications.
Yeah.
I'm assuming you mean medications that are focused primarily on the heart, but things that would be like for general tissue well-being, like potassium or bicarb,
Yeah.
etc. Those you would want us to keep doing.
And that's fine. Yeah,
Is
as
it-
long as it doesn't detract from the team's efforts at good high-quality chest compressions and securing an airway, then by all means. Yeah, I don't really see a problem with giving sodium bicarbonate or something like that. And that's kind of why I said I'm kind of wishy-washy on amiodarone, because it may work, it may not, but it's not going to hurt me to cannulate. I guess the only biggest qualm I have is against vasopressin and epinephrine, because it just makes my job harder.
what about shocks?
Yeah, I would say avoid it too,
Okay.
because again, you're telling me that you're refractory, and every single time you have to shock, now I should not touch the patient, right?
Okay.
And so if I'm in the process of putting a needle into a vessel and you say it's time to shock, now I'm stepping away and have the potential chance of losing access. Or even if you have a long wire in, now you have a wire that's flopping around that nobody has control of that could, so I would say, I would advocate for no shocks, no epi, no pulse checks, continuous chest compressions.
That's really helpful. So I think we have a script for the ACLS team, and we're really focused on that, but it's really helpful to know what's happening
Yeah.
in the groin. Tell us more about what's happening and in what order.
Yeah. So even though it's an emergency, we're trying to do this as in a sterile manner as possible. Because you could imagine that once these cannulas go in, it's not like we can say, okay, we put them in under non-sterile conditions, guys. Let's go upstairs and put in fresh new cannulas. And that doesn't happen, right? These things are going to stay in until they come out. So we want to do this in a sterile manner. We are cleaning the groins really quickly with chlorhexidine. We're getting our surgical drapes down really quickly, and then we are getting an ultrasound up, because it's all done with modified Seldinger technique and ultrasound guided vessel access, because we believe that's the safest way to do it. And so that's what we're going to do. So we're going to have our ultrasounds up, we're going to get all this equipment up, and then we're going to get into the artery and get into the vein, right? So we just need to have these small sheets, about 5 French or 6 French in size, one in the femoral artery, one in the femoral vein. That's what we're trying to do.
Talk through it for a quick minute. So
Yeah.
using ultrasound, getting a good picture of the femoral artery and vein, and you're using something like a micropuncture kit. Is that right?
Yeah, exactly.
Okay.
So we use a micropuncture kit with a micropuncture needle that has 90-degree slotted cuts in the end of the needle. So it becomes quite... on ultrasound, it lights up really, really nicely for us. So when you're sort of moving around, chest compressions are being done, this needle, it just lights up really well so we can see the tip of it. The other thing is it's a 21 gauge needle that we're accessing. So even if we hit something, then we're not causing vessel damage if we come out of it, as opposed to like a 16 gauge needle or something like that people typically
like
use.
The arrow kits and stuff like that.
Yeah, those things can just, you're talking about if you hit and you miss, you have a hematoma. And if you try to hit, for example, the artery and you miss and you have a hematoma, you potentially even lost a vein on that side. So you've lost an entire side.
Okay.
Right? So we use micropuncture kits for that reason.
Okay.
And yet you can pass a wire through this.
Yeah, so we effectively use that 21 gauge needle, and the wire that goes through that needle is a .018.
Okay.
To give you an idea, the typical wire that you use in a central line kit is a .032.
Yeah.
So that wire will not go down the micropuncture needle.
Okay.
You put this in, and then we upsize it. So the catheter that we use is a self-dilating catheter, the dilator in it inside the catheter. And it just goes in over that wire, and it dilates it from a 21 gauge needle poke to a 5 French sheath.
That's amazing.
Yeah.
I just got to stop and give a shout out to the engineers who come up with this
Right?
stuff. This is fantastic stuff. And one other question that's going through my head is, maybe before I've called you, we've done a femoral venopuncture or something like that. How does that weigh in here?
Yeah. So it doesn't matter for us if you've accessed the vein, no big deal.
Okay.
So we can go right in. If you've accessed the artery in the groin, then it becomes a bit of a we would prefer that not happen. Now, some people would say, well, if an arterial line is there, isn't it helpful for you? Can you just not wire that up and wouldn't it be faster? Yes. You're not wrong. It would be faster. But a lot of what I'm doing in an emergency is when I access that artery is not just having a catheter in there. I also know how I accessed it. I know what the angle of my needle was. I know if I ran into any difficulties. I know at the level where I am at. Because I'm doing this without fluoroscopy, and even though it's surface ultrasound and I have a TEE that is looking at the heart, I really have no advanced imaging at my disposal in the femoral areas. So unlike being in the cath lab or being in the IR suite and having fluoro to get yourself out of trouble, you don't really have that luxury. We always say that if the cannulator gets access, we love it because then we know what we had to do in order to get in there so we can troubleshoot our way out of it.
Got it.
Kind of two things that I think you're specifically, for our listeners who may be facile with getting femoral art lines, and I know that's like my favorite line in a code.
Yeah.
I think two things are, when I'm doing a femoral art line, it doesn't matter if I go in almost vertically,
right?
And that's actually technically much easier.
Yeah.
But when you have to put in a huge cannula, then you're going to kink it off.
Exactly. We're not going to be able to make that turn, and we're going to destroy that vessel.
And so that's one major issue. And then another major issue is when I'm placing an art line, I don't super care what vessel I'm in. An artery is going to be okay. So if I'm in the superficial femoral artery, I'm roughly in the same area, and I'm getting the information I need. But that could be super problematic for you.
Yeah, so we want to be in the common femoral artery, right? And we want to be in the common femoral artery about a centimeter or so proximal to the bifurcation, because we don't want to be at the bifurcation because that's where we can injure it. I have seen the profunda tear off that bifurcation during dilation attempts because the cannula sort of hit, for lack of a better word, the crotch of that bifurcation, right? And then as you're dilating, it just tears it off. And now you have a massive injury, and you're heparinized on top of that, and you have an arterial bleed. right? So we don't want these things. So we want to be in the common femoral artery. We want to be at about a 30-degree angle in order to get in there so the cannulas can go in easily under dilation and things like that. Yeah, exactly.
So what I'm taking away is, as somebody not as facile with this process, my venopuncture, central venous catheter placements aren't going to cause you problem.
Nope.
It's the arterial side. I need to be thoughtful. If the patient's potentially going to be treated with ECMO, as much as possible, avoid placing a femoral arterial line.
Yes.
Got it.
That makes a ton of sense.
Which I know flies in sort of like everything else that you're probably taught to do, get in the groin, do what you need to do, or even short of what the San Diego group does, right? Where the emergency physicians are like cannulating. But the trick there is they are the ones cannulating. So they're putting in the arterial line and the venous line, and then they're the ones upsizing. So they have that information readily at their fingertips, and they know exactly what happened.
Where we are now is we have something like a 5 French sheath in the femoral artery, 5 French sheath in the vein.
Yep.
And I've got kind of a wire there. What happens now?
Yeah, so I would say at this point, we have not done anything that is irrecoverable.
So the 5 French sheath, if I pull it out, it's not going to...
Nothing.
Patient's not going to bleed to death?
Just like an arterial line or a venous line, right? It's smaller than your central venous catheter. Central venous catheter is 8.5 French.
This is kind of what you were talking about.
Yeah.
So if I'm here and I get ROSC, I have a great art line and I have great access for the amiodarone, that's not going to help. Okay.
Or maybe it will now that you have ROSC.
Right.
I don't know.
All right.
But my point is, we have not done anything irreversible. We can take a moment here. We can take a 15-second pause. We can take a 30-second pause, and we can say, is the patient still a candidate for ECMO? Well, I use that word. See, even it slips into even me.
I've been working really hard not to say it.
I know.
But I think this is a little confusing to me. So you're saying we're at this point, and we didn't know, so we can start this without all the information.
Exactly, because information is going to come in spurts, right? You may not know everything right up off the top of the bat when this patient rolled in. I mean, what if you started doing this out of the best intention and the information that you had, and a patient's family member comes up and goes, no, he has an advanced directive, or you have a TE probe in and you find out that the patient has an aortic dissection. Right, so that's a contraindication for us to go on retrograde ECMO flow.
And this period of time in the ED, we may not even know the patient's name. And so it may be that now we figure out there's a terminal disease or a reason for which this would not be a bridge.
Yeah. So I would say information gathering can be happening in parallel while we're getting access, because we haven't done anything irrecoverable.
At this point, we've placed a femoral central line and a femoral art line, which
That's
we
correct.
would want no matter what.
Yep.
And so this is where we've done a chart biopsy at the same time and identified that this is somebody with a great baseline level of function who's otherwise healthy and would benefit from this.
You slipped in that an aortic dissection is a contraindication. Makes sense. What about aortic ulcer? What about aortic aneurysm?
Yeah, so I would say that those not necessarily unless you have a rupture.
Okay, so at this point, you've said, can anyone figure out a reason? There's a pause.
Yep.
Why this patient, it's kind of like a marriage, right? Like at somebody stands at the front and says, can anyone think of a reason these two should not be wed? And looks around and no one's raised their hand to say, I object to this marriage. What happens next?
So this is where we now move towards what I would consider that this was all, communication pre-cannulation. This would be cannulation. So
is there a soundtrack for this part? Like, okay. This sound, we've taken a big step here.
I'm a little confused on the terms. I thought we did cannulation when we gained access into the vein and the artery.
We technically did. We did place cannulas in there, but I kind of don't really see that as cannulation. I just kind of see that as kind of what Alex was driving at. This is just an arterial line and a venous line. We've started the process, but we haven't really started anything where I would consider where I'm doing something truly related to cannulation, which is where it comes now. So we give heparin first. So now we've gotten to that point where we're now going off script from standard ACLS, right? Where we're saying, okay, give heparin. So you have a blunt chest trauma patient, effectively, is what CPR is, and we're now giving them heparin. We are going to send up bigger wires and position them in the heart where we want them to be, and confirm it on echo. and then we're going to start taking dilators and start dilating those vessels back up. So that's what I consider cannulation.
In the femoral vein, there's
Yeah.
going to be a super long wire.
Yep.
And that one's going to go up to the SVC.
Yep.
When you say somebody's on image guidance, you have somebody probably doing TEE
Yep.
that then is getting a bicable
Yeah.
view and sees the tip of the wire in the SVC.
Right.
And that's why that view is super important. Does it matter if the tip is not in the SVC, if it's in the like right atrium or like what? Or
So
could that be
the
problematic?
tip of the wire is somewhat protected in the
Okay.
sense that it's a little soft. There's a J hook on it. It should not get caught into anything.
Okay.
I think having it in the SVC protects it.
Okay.
Whereas if you have it in the right atrium and you're not quite looking at it and you're moving it in and out, it can possibly go down through the tricuspid valve and get snagged the tricuspid subvalvular apparatus. I have had wires get caught there. So I think it's better if it's buried up into the SVC.
So I see that wire.
Yeah.
And then the other wire is just somewhere in the aorta.
You should see it in the thoracic aorta,
In the
ideally.
thoracic aorta.
Yeah.
All right. So we have both those views. The wire's there. The patient's just gotten a ton of heparin.
Yep.
And what happens next?
And then we start dilating. So we start taking dilators, which are exactly what they do. They just make the hole bigger.
Just like a central line.
Just like a central line, except instead of going to about an 8 French or a 9 French in a central line, we go to about a 24 French on the venous side for an adult patient, and we go to somewhere about either a 16 French or a 19 French on the arterial side.
To give listeners an idea, so when I'm placing a triple lumen, I dilate one time. If I'm going to place like a Merker catheter for dialysis,
Yeah.
it feels like a big deal. I do two dilations.
Yeah.
How many times are we going to dilate here? So for that venous
Yeah. So
drainage
let's say we're
cannula.
putting in a 25 French vein and a 17 French artery.
Okay.
Called cannulas.
Okay.
So we're going to dilate 5 times on the vein. We're going to go 8, 12, 16, 20, 24. And then on the artery, we're going to go 8, 12, 16. And then put the cannula in, right? Sometimes you can skip, depending on how it's going. I would advocate that you never skip a dilator, but we've all done it. But the tenet is you're doing it many times and you are successively stepping it up each time.
A 24 French cannula. That's amazing.
With my limited experience
It's like a chest tube.
That's exactly what I was thinking.
I think about pulling that dialysis catheter back and there's a lot happening. And then I imagine pulling back what you're describing. How do you control the bleeding in an artery that has
it's
now
the
a
same
huge hole in it?
technique. It's the same technique that you use for a dialysis line.
Okay.
It's the same thing. It doesn't change.
Okay.
So it's I take my pinky finger and my ring finger and my and my middle finger, and then I press down above the puncture site, not on the puncture site, above the puncture site, proximal to the puncture site, and I occlude with pressure.
Pressure fixes everything.
Yeah, it really does.
Okay.
And you don't see anything bleeding out, and I can still see the puncture site completely. And then using my index finger and my thumb, I control the wire, and I move the wire. So it's really the exact same way, except just bigger hole.
Pressure makes diamonds and pressure makes ECMO. That's what that's all about. So at this point, we have a really big hole and a wire still through it. What comes next?
So at this point, we start getting our cannulas up. On the venous side, the cannula is about 60 centimeters long. It has a dilator in there, and our ECMO specialist hands it up. And as I'm holding pressure and holding onto the wire, I have now stabilized it, and the ECMO specialist can load it up onto the wire on the back end, and then they slide it over to us. And once they slide it over, they make sure, just like a central line, the wire is coming out at the back of that cannula, and they give us the cannula, and then we effectively use the wire that's there as like a train track to guide it all the way up. And then I'm talking with the TE person and saying, where is it? Where's the tip? Help me get it up there.
A couple of things, because we're using this a little bit to go over things we don't get to talk about in real time. So a couple of terms. One, when you are looking to see the cannula, the venous cannula has a little bit of a sharp tip when it first goes in. It's like on a dilator.
The dilator does, yeah.
And so then there's a discussion of something's being pulled back. Additionally, then you want to see that is not going into the right atrium and it's going to the SVC.
Right.
Can you describe a little bit where you're targeting and what the potential problems are with all of these?
Sure. So the venous cannula itself has multiple holes, like we talked about, but the dilator goes through them, right, and stiffens the whole thing up, and the dilator comes to a tapered point. And that tapered point, depending on the cannula that you use, can be anywhere from 5 centimeters to as long as 15 centimeters. And because it comes to a sharp point, even though it's on a wire, we always worry about wires can buckle or they can go somewhere and you can injure the right atrial wall. We want to get it through the soft tissue. And once it's in the vessel, we sort of retract it into the cannula and bury it inside the cannula. So now the tip of that is shrouded by the cannula, but it's still on a wire rail. And then we can effectively get it up and it won't try to puncture anything.
That makes sense.
It also, believe it or not, you can see it on echo much better. It's because as the blood interface happens with the metal-bound cannula, you can see it a lot better than that rubbery, plastic, dense dilator.
Mm-hmm. The other term, something that's happening, is a lot of people are moving wires this whole time.
Yep.
Talking about racking. What's going on with that, and why is that being done?
Yeah, so just like a central line, when you're pushing your dilator in, people say check your wire, and you kind of move the wire back and forth. The term for that is racking. So we're doing the same thing, except we have a 2-person technique where as I am pushing the cannula, my ECMO specialist is checking the wire and holding pressure on the wire, either with a continuous backward pressure technique where they're just gently pulling back on the wire the entire time as the wire moves in, because you can imagine that as long as you're able to pull the wire back as I push in, that means there's no kinks in the system. And it also keeps the system nice and taut. It gives me an actual rail. So we call that like hold a rail, and we push it in. The other way to do that is because you don't have fluoro and you're worried that if you pull back on the wire, you may pull it out too much, is you kind of pull it back and then you push it in again, and then you pull it back and you push it in again. So that's called racking. The disadvantage to racking is that you don't get any information when you push the wire in. Right? Because if I'm pushing the cannula in and you're pushing the wire in and I kink, there's no way to know. I only get information when you're pulling the wire back. The advantage is because you're going back and forth, you're less likely to pull the whole thing out.
That makes a lot of sense.
So these are just like technicalities that we're working through. Mm-hmm. And this is, I think, parts of the time where it feels to the ACLS team like everything goes quiet. We go quiet down there in the sense that we're talking with each other, but we're not talking with the rest of the team. And you're just wondering, like, what's going on? The Lucas is just thumping away, and, these guys are running wires up and all this stuff. But this is kind of like what we're actively going through. These are the steps that we're thinking of.
At this point, maybe blood fills the cannulas and they're clamped. And then there's a lot of time spent trying to connect tubing. What's going on with that?
So remember how we talked about that ECMO does not have a reservoir and air is our enemy? So what we're trying to do is we're get rid of all of the air in the system while making a closed circuit. So the cannula fills up with blood, we clamp it. So now wherever the cannula is filled up with blood, there's no air there. But now we have to get there's fluid in the system, in the ECMO system, and we've cut the tubing and we've separated that. So you have a venous side and arterial side. So now we have to marry the cannula to the tubing and get rid of that air.
It all comes back to marriage. I said. Yeah. Okay. All right. So we're trying to connect the tubing.
Yeah. So just connect the tubing back up, get rid of the air. And then once the tubing is connected up on both sides, we release the clamps and make sure there's no air in the system anywhere that we can see. And once all of that is good, I have a hand on my cannula, the arterial cannula, because that's the one that can fly out. I have a tubing clamp also ready on it, not clamped, but ready to clamp. And then I tell the ECMO specialist to go on ECMO. They do. They release the clamp back there. They turn up their RPMs. We make sure this has happened at times as well, that you want the blood to come out of the vein. So we're actually looking for dark blood to come out of my venous cannula, go into the pump, come back out. When it comes back out, it needs to be bright red because we need to have gas flow on as well. And then it goes in. And then I watch that for a good 2 minutes or so to make sure there's no air, there's no complications. And then I relax.
And this has all been the cannulation phase.
This is all cannulation until flow.
And now we're in the post-cannulation phase.
Now you're in the post-cannulation phase because now you're on ECMO.
What are the key steps at this point, and where does this patient go from the ED?
Yeah, at this point, it's about figuring out whether or not you're going to get ROSC, and that determines everything that we do after that. So let's say in this scenario, it was a 65-year-old with, did you say it was a shockable rhythm at birth?
There
or did
had
you
been,
not?
but it didn't work out, didn't get ROSC. But at this point, I'm still seeing VF.
You're still seeing VF?
Yep.
So we're on flow, we have VF. This is where I would say, let's give amiodarone. Let's try to shock, because we'll perfuse those coronaries, right? The coronaries are now seeing oxygenated blood, 2-3 minutes of flow, get some magnesium on board, calcium, amio, that kind of stuff, and then shock a couple times. And did we get ROSC? Easy enough. If you don't get ROSC at all and you're still in a malignant rhythm and you've tried a few times, I think we need to go to the cath lab in order to see if there's a culprit lesion. Because, what was it, about 20% of those patients in that Minnesota consortium study needed to have a culprit vessel identified before they got ROSC. So, you can't just chalk it up and say we're done here. We got to identify that. So go to the cath lab at that point. If you get ROSC and you have ST elevations and you prove a STEMI, go to the cath lab, right? Follow your STEMI protocol. If you get ROSC and you've not had a STEMI before, or you don't have a STEMI afterwards, that's when you start to chat. Like, should we do this or should we not? Maybe stabilization in the ICU and a more investigation. You don't have to rush to the lab. If there's a vessel injury or something else is happening, then you may have to go to the operating room in order to fix that.
What are your thoughts on comprehensive imaging at this point?
I think if there's not emergent need to save the myocardium or another complication that you're trying to prevent, like exsanguination from a femoral artery injury or like pericardial effusion or something like that happened during cannulation, for which you need other procedures that are more life-threatening, then I think it makes sense. Again, it's technically blunt chest trauma to
blunt trauma patient, 100%.
Right? Yeah.
And so what we're saying overall,
to that end, you can take the patient and the circuit through CT.
Absolutely.
What about MR?
Not MR.
Okay.
Yeah, not MR. But,
certainly ultrasound and X-ray are fine.
Yeah.
Okay.
Ultrasound, X-ray, CT scan. Yeah. And you can CT scan and do all the same studies that you would normally do. You may just have to work with the radiologist to kind of alter their protocols and their timing on when they give the contrast, given the fact that you have retrograde flow. But other than that, yeah.
What I'm hearing is if we have a very high index of suspicion for a culprit lesion, either a STEMI, persistent arrhythmia, cath lab.
Yep.
If at this point we're still a little bit up in the air about the etiology, we're probably going to get whole body CT to dig a little bit deeper, and then also to look for complications from ACLS, complications from the ECMO
too.
Yep.
Yeah.
We're going to go to the ICU and we're not going to forget a distal perfusion catheter.
We will not forget the distal perfusion catheter. Okay. More often than not, when we're waiting for the CT scan or waiting for the cath lab to get ready, you would think that you're saying, okay, we're on ECMO, we got to go to the cath lab. You and I know that doesn't happen. No matter how well we try, it even if we're ready, it takes like 5 to 10 minutes to get a card in there or something else, or what have you. Got to suture these things in. Take the time to suture the cannulas in. Don't let them be free falling. That's a rookie move. And then put in a distal perfusion catheter if you have the time. Okay. So more often than not, what we do is, because we have 2 cannulators, once we're on flow and we take a couple deep breaths and we decompress, one of us will start working on the distal perfusion catheter. Well, the other person is like interacting with the ACLS team and figuring out next steps. We both don't need to do that. That can still happen in parallel, right?
Absolutely.
We've touched on a few complications that can happen. Yeah. You talked about the arterial cannula falling out, etc. Help me understand, what can I be prepared for that might go wrong when things don't go?
I would say the most common thing that I hear is, what is the blood pressure that I should be targeting?
Yeah.
Right? Because you won't necessarily think about that guided resuscitation in the code. But what ends up happening here is, as soon as we go on flow, we go on full cardiac support, or equivalent of full cardiac support. So all of that epi and vaso and everything else that's been in there starts circulating, and you will get massively hypertensive, and then you'll have a washout, and then you'll get hypotensive. And so the key is, during that acute management period, making sure that maybe you have some propofol or clofidipine or something else to bring that blood pressure down, but recognizing that in about 5 or 10 minutes, as soon as that washout period is done, then you're going to end up back on pressors. So I would say, just like everything else, target a mean arterial pressure of about 65 or so. So I would just do whatever is necessary for that. We can always adjust our flow. Your MAP gets up to 150, we'll come down. But I would rather keep perfusing with flow as opposed to moving the flow back and forth for a targeted blood pressure. Well, we have other tools.
And you're thinking propofol and clofidipine are probably our best.
They're easily available, whatever you choose. I mean, that's kind of what is in my hands in the ICU and in the operating room, but whatever's available at, wherever you guys are.
Excellent.
But resist the urge to massively come down on your drugs or eliminate them. So if you've been on a norepinephrine drip, maybe you don't need 0.3, but maybe you'll still need 0.1. You know what I mean?
So don't throw it in the trash, you're saying.
Yeah,
don't disconnect it, tangle up the wire.
Because you're going to need it very quickly.
Okay.
Even more importantly, I can see myself being completely confused. Why is this happening? What's going on with the patient? But this is expected.
Yes.
An immediate or a short-term rise in the blood pressure followed by a return back to the hypotensive state afterwards.
Yeah. The other stuff that could happen is if we tell you that, we have had an injury in the femoral artery or something, you may sometimes just all you'll hear us say is there blood in the room? Can we get some blood in the room? If we're asking for that, it's either because we're seeing a hemodilution effect on the circuit or because we're having some bleeding problems or we're anticipating that we're going to have bleeding problems and we want some blood in the room. So if we can get type specific blood, great. If not, just having packed red blood cells would be fantastic. Those are really the majority of the issues that can happen is either bleeding or hemodynamic instability because we just came up on flow, right? The rest of the stuff we have time to work with.
Okay, so I think we have a much better idea of what the blood's doing, what the people are doing, and now I'm kind of looking to the present and future.
Yeah.
When we're thinking about the reason to do this, I just want to get your general idea on the landscape of the literature. What literature do you think supports this practice? What do you think of the papers that are a little bit more equivocal?
Yeah, I mean, if you kind of look back at the randomized control trials that have looked at ECMO in general, all ECMO, okay, you kind of have the Caesar trial that first started, looked at VV ECMO for ARDS, and the question that it asked was, if you transfer the patient to an ECMO-capable center, is it better for mortality as well as is it cost effective? In that metric, the trial was positive. But if you just looked at the patients that went on ECMO and the patients that didn't go on ECMO, the trial was actually negative in terms of survival. Right?
Okay, so getting good critical care is good for people.
It's good for people.
Okay.
It's kind of, okay, great. And it's cost effective. So then those criticisms came about, and then the Eolia trial came, and it specifically said, okay, early randomization into these two groups, mechanical ventilation versus ECMO within the first 3 days after we met these criteria, all of this different stuff.
And this is still VV, is
still
that right?
VV,
okay.
Right? And that trial was negative, right? The p-value was 0.09, and it didn't quite hit significance. Now, yes, there's papers out there that talk about how if you do a Bayesian analysis on it and all of this stuff, and 20% was never an outcome, that the absolute difference was never something that they would have hit. Yeah, you can cut it however you want, but the reality is it didn't hit significance, and it's a negative trial.
Why would VV ECMO be expected to work in a cardiac arrest?
No, but I'm just saying in general, this was for ARDS. Yeah, I was trying to get to the point that if you look at all of the trials that have happened, the large-scale randomized controlled trials in ECMO, none of them are positive. The only one that's positive was the ARREST trial, which was stopped early after review because they said that, I think, only one patient or no patients in their control group survived.
One to discharge, but none to 30 days, as I recall.
And then it was like about 40% or 45% in their ECMO group. And so the trial was stopped after 30 patients enrolled?
50 in each group.
So that's the only one that we have that's positive.
Okay.
The hyperinvasive trial that followed after that for cardiac arrest in Prague, negative. If you look at the subgroup for shockable rhythms, there's a signal for it to be positive.
Am I misremembering? I thought Prague had a 10% improvement in survival in the ECMO group, but they had set a priority mark of 15.
Yep.
So that's why they said it was negative.
Exactly.
Okay.
And they had a higher than expected survival, I think, in their control group.
Yeah.
And then you look at the, what was the last one that just came out? Inception. Yeah, Inception.
Great movie, but
yeah,
tough trial.
Yeah, negative, right? But then you look at those same authors and you talk to them about it and they go, well, yeah, we actually doubled our survival when we did training and simulation. So you look at that trial, there's a lot of patients that were going on ECMO. Their cannulation times were like 50 plus minutes, over an hour. And a lot of centers that were doing ECMO that had barely ever done it before. So it makes sense that they would say that their survival got better once they had more training and simulation and things like that, which is kind of what we're finding. If you look at our numbers, we're at about a 35% neuro-intact survival rate for our ECPRs over the last 4 years of data combined, and we've gotten better every single year.
That includes out-of-hospital cardiac arrest too?
Yeah.
That's phenomenal.
Yeah. So we're doing pretty well in that regard. But if you are you asked a question about literature, it's technically all negative trials.
Yeah.
So if you were sort of like an ECMO naysayer, you would say like, guys, what are you doing? I have a few cardiology friends who say that based on the newest ECLS shock trial that came out, which looked at ECMO for AMI cardiogenic shock, where there was no benefit in mortality, that ECMO should be relegated to phase 3 clinical trials only and not part of routine practice, which surprisingly I don't agree with.
Because we opened the show with,
yeah,
you're an ECMO believer, as
but
am I. Okay.
Also, look at who else doesn't agree with it. It's the AHA. Their latest ACLS guidelines come back with ECPR as a level 2 recommendation right now. And it's actually part of their algorithm. In fact, their algorithm for who should be considered for ECPR is even more liberal than what we use. Their age criteria is 75. Ours is around 65 to 70, I want to say, depending on the time of day that we pick. And then even their transport window is slightly larger than ours. So I think they have a 45-minute transport window and we have a 30-minute transport window. But the idea being that, now we're just, trying to nitpick at it. But the point being that the AHA is coming around to it. I just did my ACLS recertification and there was questions on ECPR in the thing, which I'd never seen before. I think while the trials are negative, there's a reason why they're negative, and we can always kind of see where it is. And I would say the benchmark for me is what Dimitri Anopoulos is doing up in Minneapolis. That's the best process that we've tried to emulate here, trying to get them on in less than 30 minutes, trying to get to the cath lab and identify those culprit lesions. Having one great reason to stop care, not 5 so-so reasons to stop care. You've committed to this patient. So don't be wishy-washy about that commitment. Most of these patients for ECPR get decannulated around the 5-day mark on average. But neuro-intact can sometimes take 20 days. So there's good critical care that's needed. And if you give up on these patients, then your numbers are going to look bad.
Yeah.
So one great reason to stop, not 5 crappy ones.
So what I'm hearing overall is we see this body of literature. There's the arrest trial, which was a positive trial. Inception and the hyperinvasive trial, there wasn't a positive finding, but there were some questions raised. Is the subset of patients with shockable rhythms, is that really who we should be targeting?
I think so.
And then I think Inception raised questions of, is ECMO a magic bullet?
Yep.
Is that the thing that's beneficial in what you're saying? And I wholeheartedly agree is it a technology and a system that you have to design to implement? And it seems like what Dimitri Anopoulos is doing is really an effective system of fast care that we all want to emulate.
We know the machine works, okay? It removes carbon dioxide, it adds oxygen, and it moves the blood around. There's no doubt. The machine works. We need to stop asking the question, does ECMO work? And we need to start asking the question, how do we make ECMO work? And that's I think the crux of what all these trials are getting at, and kind of what I got back to at the beginning. For which patient is the benefit going to outweigh the risks? and how do we make it a success for that patient? That's going to be a bit of an iterative process. And in my mind, there's not been a single trial that has really addressed that.
I think it goes back to our common value of the best interest of the patient is the only interest we'll consider.
Yes.
So.
The Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda.